Hi, everyone. So today we're looking at conduct disorders. Now, conduct basically means behavior. And if I read this quote by John Bowlby, who we know from the evolutionary perspective, he does say that those who violate social and criminal codes do so for very many reasons. Before studying our cases, we must do our best to group them into different sorts. So what this basically means is that there are people who do all sorts of different things, behavior wise, legal wise, that are considered wrong, according to society. But we have to basically figure out, well, why are they doing these? Is it a conduct disorder or something else? So why study conduct disorders, or CD, which I might refer to it as CD in the PowerPoint or in the lecture? But it's really, really important to take a look at this, because actually about 30 to 50% of all child referrals to mental clinics are for conduct problems. So this is a vast majority. Almost half of the reason why children are being brought to mental clinics are for their behavior issues. And why are they being brought there? Again, it's because it affects family members, the parents who have to raise them, family who are around them that are having to deal with these usually negative type of behaviors, and they want help for it. So it is the most frequent reason why children and adolescents are referred to mental health clinics. We do have to consider that there are many different types of behavior issues, different pathways or outcomes, basically what's going to happen to these individuals as they get older, and reasons why these conduct problems or disorders come about. Now, even though it's also the most frequent reason why children are brought to these mental health clinics, it also is extremely costly. Now, if we take North America, for example, we do kind of look at the increasing cost of having to deal with children with conduct disorders. There's annual public costs, healthcare costs, and as they get older, if it's not treated or in quotes cured, of course these behaviors start to have dire consequences. If we have to take a look at the juvenile justice system, or even the educational system in terms of educating children, adolescents, and their family members about conduct and behavioral disorders overall. Not only does it affect their behavior, but of course it does impact the child's emotional and social well-being. It can affect their academics in terms of how they deal within their school setting. Of course, family relationships, and as they grow and develop their future well-being as adults in society. So what are conduct disorders? So we have a variety of descriptions here. So in the DSM-5, we are looking at it being considered under the category of disruptive impulsive control and conduct disorders. So if you remember that document that I gave on the DSM-5 and all the different categories, there was a particular category called disruptive impulse control and conduct disorders, and conduct disorders falls underneath that category. Actually, there are two different behavioral or conduct disorders under that under the disruptive impulse control and conduct disorder category, the other one being ODD, or oppositional defiant disorder. Both of these have been found to predict future psychopathology. So what this means is that if a child does have conduct disorder or oppositional defiant disorder, they're at a kind of a great likeliness in terms of predicting future psychopathologies, having some kind of mental health issues later on in their life. So these are what they are repetitive, persistent patterns of having severe, aggressive, or antisocial acts. Now, the term antisocial, we can look at antisocial being informal or formal type of antisocial acts. The definition really of antisocial is looking at, being contrary to the laws and customs of society, devoid of sociable instincts or practices. Now, some antisocial behaviors even appear and decline in normal development, and this even may vary in severity. So what this means is that if you do have antisocial behaviors as a child, this could be normal, because we need to look at it in terms of age appropriateness. So when age appropriate norms are violated, you basically think, most toddlers around the age of 2 or so, 2, 3 years old, they do tend to hit, they do tend to kick, bite. They might learn to lie, intentionally break things, learn to say no, saying no all the time, resisting authority, etc. But most of them, these children learn to control those behaviors by the time that they enter school. And that would be normal, okay? However, some antisocial behaviors do decrease with age. Others actually increase with age and opportunity. So for example, hanging out with others who get into trouble, you might start doing some of those things again. So the disruptive and rule violating behaviors can range from, just being kind of minor behaviors like temper tantrums to, of course, more severe antisocial behaviors, vandalism, theft, assault, that they can also get into, get into a lot of trouble in terms of legally later on. So going from, biting, pushing, hitting, progressing that to beating people, inflicting cruelty as the child becomes older. These are, things that would suggest perhaps conduct disorders. This is taking a look at the criteria in the DSM-5. Now, conduct disorders was actually established as an official disorder in 1968, which was the DSM-2. But symptoms have actually been seen in research for many, many years before that. So if you take a look at the diagnostic criteria here, we do kind of have these major categories: aggression to people and animals. And you can take a look at some of the things that they may do to people or animals, force someone to sexual activity, cruel to animals, cruel to people. Destruction of property is another category, setting fires to other people's property or their own. Deceitfulness or theft, breaking into someone's house, shoplifting, those kind of things. Serious violation of rules. So maybe being a runaway or not going to school, those type of things. Okay, so that's a little bit of criteria from the DSM, and a little bit more here in terms of specifying whether it's a child onset. So basically, do these symptoms or characteristics show before the age of 10, or if conduct disorder is more of an adolescent onset, meaning it comes after the age of 10. Okay, so these are really kind of the major aspects in terms of determining or specifying. Did it come before, like during childhood or during adolescence? You can also take a look at some of these other in the PowerPoint file, some of the other things that may occur with conduct disorder. And we'll talk about some of these, callous lack of empathy, those kind of things as we go on in this lecture. And then I did mention, of course, we do kind of have these different levels of severity, this one going from mild to moderate to severe. Here are a few vignettes or like case studies for you to take a look at. I'll just read, one or two of them, and then you can read the rest in the actual PowerPoint file. But just to give you an idea, so Andy threw his booster seat in my face and hit my jaw. He thought it was funny. He was acting up, and I think he had already had one time up for yelling and screaming and interrupting us at the table. And I said, "Fine, you're not having dessert." He flew into a rage. He picked up a metal fork and threw it at me with all force and hit me, barely missed my eye. There was blood on my forehead. I was hysterical. I was terrified to see that type of rage in a 4-year-old. So of course here, we're looking at not just perhaps a simple, temper tantrum, but really kind of perhaps inflicting pain on other people and having other people being terrified to being around, just a simple or a young 4-year-old. Here it says, in one 5-day period last March, he threw a rock at a girl at the YMCA, hitting her in the head and drawing blood, set fire to his room, pushed his sister down the stairs, whipped the family dog with a chain, and stole $20 from his mother's wallet. So again, this was, talking about some of those different things in the DSM, again, inflicting pain on other people, the kind of the liking to set fires to property, animal cruelty, stealing, these kind of things that could lead, of course, to more conduct problems and more legal problems later on in life. Actually, if I mention about legal problems, however, right now, legal definitions actually exclude antisocial behaviors of very young children when occurring in the home and school. And if you want to look at, what's considered to be juvenile delinquent or juvenile delinquency from a legal standpoint, most Western countries look at that from about 12 years old on. So before the age of 12 years old, it's not considered to be juvenile delinquent. Again, depending on the countries. And of course, there's different, provincial or city type of legislations. And just some other examples from here. Stabbed the father in the calf. After stabbing, Steve felt like he was going to get beaten because of his father. His father had a long history of physically abusing boys. So then he fled with the cars without permission, crashed in a field. But stealing the car, just other issues here that we can see that match up with what we read in the DSM earlier. So there are some other effects on the child. Specifically, again, we mentioned behavior. We mentioned issues with social and emotional aspects. We mentioned academics and family life. Young children with conduct disorders or chronic problems do display those poor social skills. They tend to have verbal and a physical aggression towards their peers. They often actually overestimate others' aggression towards them. So they might think that someone's in quotes, coming at them or going for them. But in reality, they're overestimating other people's aggression, and then they underestimate their own aggression. So they think they might not hurt by doing something to someone as much, but it does hurt a lot. Okay. Often they are rejected by their peers within the school, although they could actually be popular. But reasons why they might be popular is because others are afraid of them. So if you stick by that child, maybe they won't hurt you. Some of them become bullies. But again, why do some bullies do have a lot of friends? It's because they're feared. Children who are rejected in primary grades are 5 times more likely to display these problems as teenagers. They tend to have, again, those aggressive actions. Over time, it can permit them to rationalize their antisocial conduct because of their high self-esteem. So they might look at themselves and feel good about themselves, but that allows them to think that what they're doing is okay. Overall, we could be looking at some underachievement, not trying as hard in school, being held back certain grades, so failing a grade perhaps, to dropping out, to being expelled, suspended, or maybe needing special placement in the school setting. Now, school is actually particularly challenging for these children. Because of the fact that, teachers, expect certain rules to be followed. You have to sit still all day. You have to raise your hand. You have to be quiet, spoke when you're spoken to, those kind of things. There's a lot of boundaries and rules to follow and expectations in place, as well as the authority from the teacher. So there's a grown up there who's kind of, in quotes, running the show. You're supposed to listen to them as the authority, and they have a lot of problems with that. In terms of epidemiology, the prevalence is about 2 to 8% of children in Canada do suffer from conduct disorder problems. Now, I did mention that there's 2 different types of disruptive impulse control type of behaviors. So ODD is actually more prevalent than conduct disorder during childhood. However, by adolescence, the prevalence is equal. So more children have oppositional defiant disorder than they do conduct disorder. But again, by adolescence, it is equal. In terms of gender differences, we are looking at this evident by about 2 to 3 years of age, where boys tend to have an earlier age of onset and tend to have greater persistence. So they're more aggressive and it lasts longer compared to girls. So during childhood, rates of conduct problems are about 2 to 4 times higher in boys. They are earlier. And again, they might have more of those overt type of aggressive behaviors, theft, and so on. And girls might have those early symptoms of sexual misbehaviors. In terms of comorbidity and other disorders that might go along with conduct disorder, more than 50% of them do have attention deficit hyperactivity disorder, and about 50% or half those children with conduct can also have depression or anxiety. So the Anxiety may serve as a protective factor actually to inhibit aggression. So they might want to not be aggressive, but to kind of hold that back, their anxiety rises. And even the increasing severity of antisocial behavior is associated with the increased severity of depression and anxiety. So the more antisocial behavior they have, usually the more severe the depression and the anxiety are. Okay, let's take a look at some etiology, so the causes in reference to biological factors. Now, I start talking about two different systems that we have in our brain, the behavioral activation system, or BAS, and a behavioral inhibition system, which is BIS. Now, first, I'm going to tell you what the behavioral activation system is for a typical individual, and again, the behavioral inhibition system for a typical individual, and then we'll relate it to those with conduct disorders. So what a behavioral activation system is for a typical individual is basically kind of the understanding that, they would want to work harder when they know that a reward follows. So if someone is working and they know that a goal is coming, or sorry, they know that a reward is coming, they will tend to work harder to be able to get that reward. Now, this seems to be overactive in those with conduct disorders. So this particular system is overactive. It's working too much, meaning they really, really, really want that reward and they need that reward in order for them to work. If they don't get the reward, pretty much it's as if they won't necessarily work hard. The behavioral inhibition system in the typical individuals is that they tend to be very sensitive to signals of punishment, which inhibits movements towards goals, which relates to fears and anxieties and so on. So what this is saying that is that if a typical individual is moving towards a goal, but they feel like they're very fearful of getting the goal, or fearful of the things that they need to do to get to the goal, they have anxiety and so on. This is basically punishment. Being fearful, having anxiety, this is a punishment towards themselves. So this will stop them from moving towards a goal. This is a typical individual. Now, this seems to be underactive in those with conduct disorder. So they're not sensitive to punishment. Punishment actually doesn't do very much for them at all. And they'll move towards their goal no matter what. They don't seem to have the same fears or anxiety in moving towards the goals, and therefore they will do it. So these are basically, again, looking at the difference between, it's almost like these two neural systems are related to motivation, one for reward, which is the activation system, and one for punishment, which is the inhibition system. We also have some different structures of the brain that seem to be different in those from a typical individual to one with conduct disorder. So we have some structural and functional brain abnormalities in different parts. For example, the amygdala, which is actually related to emotions. So again, they might have more of a lack of empathy, lack of emotions towards other people or themselves. So this has to do perhaps with the fact that their brain has the abnormal amygdala. We could talk about some subcortical neural systems. Now, again, if you don't know what subcortical means, it's kind of like a deeper level or a deeper layer in the brain. So specifically the subcortical neural systems, for them, it does impact their moral reasoning and perhaps even their behavior. Okay, the prefrontal cortex is known a lot for kind of the higher order processes of thinking, such as decision-making circuits, social and emotional information circuits. And again, this seems to be abnormal for them. So that does kind of play a role in terms of their decision-making circuits. They tend to make, again, poor decisions based on what society would consider to be acceptable. And again, their social emotional information circuits are not wired in quotes properly, and therefore, again, they have that lack of empathy. The frontal and parietal regions are related to, different things. Again, similarly to what I was mentioning before with the emotions, we have emotions in our frontal region and our parietal region as well. So very, very or kind of in the same area, that kind of the frontal and parietal section. It also talks a lot about emotional and impulsive motivational urges. So again, they might be more impulsive than the typical individual, and their motivation behind doing something is not what society would consider to be acceptable. And then we could talk about the anterior cingulate, which is towards the back of the brain. And this in particular, again, it talks about empathy. So we have a lot of structures so far that relate to empathy. And again, because it's dysfunctional, if you will, they tend to have a lack of empathy. And then the insula is related to social decision making. And again, not making the proper type of decisions. We can continue on talking about some more nature-related causes. So neurobiological causes right before is also nature-based, and so are genetics. So this may be linked to chromosome 2. If I never talked about this before in class, just to let you know, the Human Genome Project is an organization that took a look at all of the chromosomes that a typical individual has and was able to map it out to talk about the responsibilities and functions of those chromosomes. Now, a typical individual has 23 pairs of chromosomes per biological parent, resulting in 46 chromosomes per human cell. Now, it is possible to have less than 46. It's possible to have more than 46. It's possible to have 46, but they could be broken or damaged. Any kind of combination that you look at it, if it's not 46 healthy chromosomes per human cell, then we're looking at something basically going wrong, whether it has to do with a medical condition or a psychological condition, and so on. So if I talk about chromosome 2, it's actually the second largest chromosome that we have, that humans have, representing about almost 8% of total human DNA. Okay, so the second chromosome is where this seems to have some kind of genetic marker on it to relate to conduct disorder. Now, I can also talk about antisocial personality disorder. Now, antisocial personality disorder is not a part of the disruptive conduct disorders I was talking about before, where we have conduct disorder and ODD as subtypes. Antisocial personality disorder is considered a personality disorder in the DSM-5. So, but why I'm talking about this is that conduct disorder often leads to antisocial personality disorder in adulthood. Whereas conduct disorder is a childhood related disorder, antisocial personality disorder is an adulthood related disorder, but that stems usually from conduct disorder as a child. So when I talk about the words antisocial, I am referring to, of course, the characteristics that children with conduct disorder have and adults with antisocial personality disorder have. Okay, so here's where we're getting to, because I'll mention antisocial quite a bit from here on out. So when we're looking at the genetic influences, we have seen that aggression does run in families, and antisocial behaviors and tendencies run in families as well. Now, aggression and antisocial behaviors are actually universal, meaning we all typical individuals, all atypical, have some sort of aggression and antisocial behavior. However, again, the depth and the, I guess, how extreme the aggressiveness and antisocial behavior characteristics are do depend on some genetic influences that have been passed down from generation to generation. We have seen in research a link between parental criminality. So if a parent is a criminal, that it does, that there's a higher chance, again, that it could run in families. And this is also due to the aggression and antisocial tendencies that parent criminal may have. We could also look at some adoption and twin studies. So this is often done when looking at either concordance rates or, just wanting to know the difference between nature and nurture. Of course, nature, we could be looking at more of the twin studies where they have about 50% of the same DNA if they're dizygotic or fraternal twins, or 100% of the same DNA if they're monozygotic or identical twins, versus those who grow up in, a different household than their genetic biological parents, and therefore it is more environmental. So this is the whole this is nurture and this is nature. Taking a look at those type of studies, it does indicate 50% of or more of variance of antisocial behavior is hereditary. So, about half of it does come from nature, whereas again, this does of course suggest the fact that it's a contribution of the environment and genetics alike to make someone have perhaps conduct disorder going into antisocial personality disorder. And let's continue on talking about some environmental factors. So we talked more nature-based, but here is more nurture environment-based. We could talk about some attachment theories. Now, if you remember, Mary Ainsworth talked about attachment theories in infants with the whole idea of the strange situation. And she did link some insecure attachments to disorders. This one in particular, she did say there's a relationship between some insecure attachments and the development of antisocial personality disorder. And then if you want to look at it, that's more of an adulthood related factor, the antisocial personality disorder. However, just kind of as childhood related characteristics, even those insecure attachments could just lead to antisocial behavior overall. Familial instability and stress. So if the family is unstable, so maybe there's a lot of movement going on, so multiple family transitions, maybe a low socioeconomic status, unemployment, those type of stressors can increase the child's antisocial behavior, maybe harsh parenting. So maybe a very authoritarian type of parenting could play a role, domestic violence in the household, just kind of the just not a stable type of family, and the increasers of stress do increase the child's antisocial behavior as well. And overcrowded environments are extremely important, because of the fact that we think about just putting too many people in a small space. Okay, so no, we don't have to all live in mansions and have 10 rooms to ourselves, but having too many people in a small space has been shown time and time again in research that this is a disadvantage psychologically to anyone, child, adult, etc. So overcrowded environments are an issue. Now, these are often associated with unfortunate family and neighborhood circumstances, all of these things here. Either way, that it occurs, the circumstances do not excuse the behaviors, but it perhaps will help us understand and prevent it. And we do have also some prenatal factors and birth complications. So perhaps low birth weight may play a role in conduct disorders. Again, why would someone have low birth weight? Perhaps because of particular teratogen that may have played a role in the low birth weight, which could include malnutrition from the mother. So a possible protein deficiency during pregnancy can lead perhaps to the low birth weight, could lead to, again, the conduct disorder and antisocial personality disorder. Even lead poisoning as a teratogen. So coming into contact with lead during pregnancy can also play a role in conduct disorder or antisocial personality disorder, and other teratogens like nicotine, alcohol, marijuana, and so on. Okay, let's talk about age of onset. So when does this come about? In the DSM-5, it does talk about two different types of conduct disorder. So childhood onset conduct disorder basically means onset means when it comes about. So it comes about in childhood. So those children display at least one symptom before the age of 10 years old. They're more likely to be boys, if you want to give some kind of statistics behind it. If they have childhood onset disorder or conduct disorder, they're more likely to be aggressive compared to those with adolescent onset on conduct disorder. They're more likely going to account for a disproportionate amount of illegal activity, and they're more likely going to be to persistent antisocial behavior over time. So what this means is that if they were having childhood onset conduct disorder, this actually has a worse prognosis as they grow up. They tend to not outgrow the conduct problems. It tends to get worse and turn into antisocial personality disorder, and they tend to do worse in adulthood as well. Those who have adolescent onset conduct disorder, we do have kind of the equality in the sex here, where it's as likely to be girls compared to boys. So both boys and girls are equal in terms of who is affected by it. They don't show the same amount of severity or psychopathology characterizing this particular group here. So they tend to do, they're not as severe in their conduct problems or behavior or antisocial behavior itself. And they actually have a better prognosis, meaning if they're only diagnosed with adolescent onset conduct disorder, they might outgrow it or be able to be treated. It won't be something perhaps that would for sure end up in antisocial personality disorder. They could possibly get out of this maybe fine. Okay, so they're less likely also to do kind of those illegal activities like committing violent offenses. Okay, let's take a look at the developmental pathway. Where is this going? Where does it start? What's the kind of okay, let's take a look at the developmental pathway, where it starts and then how it progresses over time. And we can see that there are some different forms of what's considered disruptive and antisocial behavior. Now, actually, the earliest sign of perhaps disruptive and antisocial behavior leading to conduct disorders and perhaps antisocial personality disorder is actually difficult temperament in infancy. So kind of before the preschool years as an infant, the very first sign perhaps is having a difficult temperament in infancy. Now, if you don't know what temperament is, it's very similar to like personality. So it starts off with that kind of difficult infant, and then leading to some hyperactivity and impulsivity during preschool and early years. During the preschool years, actually, we have a peak in oppositional and aggressive behaviors. So again, oppositional, really kind of the defiance is there, and being a little bit more aggressive, perhaps, biting, fighting, those kind of things. As we get into elementary school, we actually now have a diversification. So new forms of antisocial behavior tend to develop over time, such as withdrawal, a poor peer relationships, academic problems, starting to convert or conceal conduct problems. And then problems become more frequent during adolescence. So it happens a lot more. They tend to have associate with deviant peers, so hang out with people who perhaps will be recruited into will help or will want to recruit them into early delinquent behavior. Actually, early maturing boys and girls are at more of a risk for recruitment into delinquent type of behavior by their peers. And then, of course, we look at severity kind of increasing. So problems become more frequent and more severe throughout adolescence. Now, there are two common pathways where this can go. Now, we did talk about two types of onsets. We talked about childhood onset and adolescent onset earlier. Now we talk about, well, where is this going in life? Now we can talk about an adolescent limited path. And then we could talk about a life course consistent path, or LCP for short. The adolescent limited path actually has a better prognosis compared to the life course persistent. So adolescent limited path, this is similar to the adolescent onset, starts at puberty and ends in young adulthood. So it doesn't persist past that. Once they're an adult, perhaps, everything is typical and fine. But those who are on the adolescent limited path, they tend to have less extreme antisocial behavior. They're less likely to drop out of school, and they have stronger family ties and support. Now, their delinquent activities often related to perhaps peer influences or something temporary. So this is limited to adolescence. However, the worst prognosis again is the one where we look at life course persistent. So begins early, perhaps in the childhood onset, and continues on throughout their life into adulthood and through adulthood. Now, this antisocial behavior, like I said, does begin early. We could perhaps look at, different antisocial elements in the social environment, as well as nature-related aspects, so both nature and nurture that play a role in making this stay throughout the child's lifetime as they grow. Now, some children break from the traditional progression, and about 50% of children with early conduct problems do actually improve. Some don't actually display problems at all until the adolescence. And then again, some do display persistent low-level antisocial behaviors from childhood and adolescence throughout adulthood. And actually, if we look at this kind of idea of the life course consistent persistent path, 8% of those with conduct disorders end up having a lifetime persistent path. So a smaller amount end up having this throughout their life. And there's actually still more males than females that are affected. Now, continuing on, again, even though we talk about childhood related disorders, this is our last topic, and we kind of meld it into, well, what's going to happen later on in life? I did talk about antisocial personality disorder, but I need to tell you a little bit about how it differs from a childhood related disorder of conduct disorder to this one, which is antisocial personality disorder. So those with antisocial personality disorder often have not the nickname, but people use the term psychopath to describe those with ASPD. Now, a psychopath, it tends to have a very cold type of heart, uses aggression in a planned way to get what they want, and they're very calculated in their moves. The diagnosis of antisocial personality disorder is relevant in understanding childhood conduct and their adulthood outcomes. It is classified, like I said, as a personality disorder. It's within the cluster B. If you look at the DSM-5, this goes along with borderline personality disorder, narcissistic personality disorder, and so on. Those are all kind of sub disorders from the personality disorders. Now, those who do have ASPD, they tend to have a very pervasive pattern of disregard for and violation of the rights of others. They're very, very selfish in their motives. Everything that they do is for themselves, and it doesn't really matter who they trample or who they have to hurt to get to their goal. And it often involves multiple illegal behaviors. So as written here, it does say that as many as 50% of children with conduct disorder end up later developing ASPD around the age of 18 years old. So again, conduct disorder is a precursor to ASPD. And again, this being an adulthood disorder, ASPD, we have to look at the kind of the early prevalence or the kind of the early ideas of what led to it, which is conduct disorder. In order for them to be diagnosed with ASPD, it has been said in the DSM-5 that they should have already had conduct disorder by the age of 15, leading into the ASPD as adulthood. They also have a sign. They also show signs of lack of conscience very early on in their life. So really, kind of not really choosing right from wrong the way that society believes that you should. So kind of around the age, I kind of talked about the id, the superego, and the ego earlier on in the semester. The superego kind of talks about morals and values. And they tend to have a lack of this kind of conscience. They're very, very selfish by nature. They often violate laws. They can commit crimes. They often lie. They behave violently, engage in pyromania, or really like kind of setting fires to things. Very cruel to animals. Treat other people harshly. They're very manipulative in what they do. But one interesting thing about them is that they can come off actually as very charming. They look very charming. They look like they're nice. They act like they're nice, but it's all an act, because what they're doing is they're being charming so they can manipulate you and get what they want. So it comes back down to selfish in nature. Many of them do display callous and unemotional type of interpersonal styles where they don't feel sympathy or empathy for others. Now, the term psychopath, again, is often used. Sociopath is often used as well. Now, if you look at the two, sometimes they're considered to be interchangeable: psychopath, sociopath, someone with antisocial personality disorder. But generally, if you want to look at the difference between psychopath and sociopath, a psychopath is actually more dangerous because they pretend to care, whether compared to a sociopath who could tend to look more angry or be more angry and don't really care too much about others. The psychopath is more dangerous because they pretend to care, so it looks like they're charming, but in reality they are not. Now, past childhood, what happens with all of this is that, again, once they're into early adolescence or late adolescence, we could be looking at the delinquency becoming more severe. We could be looking at drug use, increased sexual activity or sexual risk taking. Again, we could be looking at criminal behaviors. So active offenders, 50% being active offenders, tend to decrease by early 20s, and then by late 20s, kind of done with the whole idea of illegal kind of behaviors. So still looking at the fact that for the most part, many people kind of are treated from this, because again, only late 8% of people have that life course persistent path. Now, negative adult outcomes are seen, however, from this, where they could be, again, more criminal behaviors, have problems with work, depression, suicide, and so on. You can take a look at this list here, and tend to be strongly associated with substance abuse and substance use disorders later on. So if you want to talk about comorbidities later on in life, having kind of the disorder related to substance abuse. And we can look at the rates of premature death because of kind of the judgment issues that they have. So judgment skills are not really quite there. And of course, the type of delinquent behavior that they get themselves into, they tend to have more of a premature death. So perhaps by the age of 30. And this is 3 to 4 times more higher in boys who do tend to have those conduct problems early. How does this affect other people? You can imagine again, just especially that, the conduct disorder as a young child, your child doesn't listen to you, your child defies you, lies to you, steals, has a hard personality, etc. Of course, this affects the family because the family is usually around the child all the time. So this, parents and family feel that the children are out of control. They feel helpless to do anything about it. And therefore, again, we have, some of these ideas of, high levels of conflict between the family, especially during, between siblings, lack of family cohesion, how to deal with the child, and maybe differences from one parent to the next, lack of emotional support, parental social deficits, and so on. And last but not least, looking at treatments and what can we do? What can we do to help the individual? What can we do, for the people around them, and so on. Now, usually we try to stay positive and talk about treatments that do work, but it's also important to kind of understand what does not work. So we do have these ineffective treatments to discuss. Now, a lot of times when we talk about other psychological disorders, having individual counseling within the office, tends to work very well. Family therapy tends to work very well, but this one is pretty ineffective when it comes to treating conduct disorders and antisocial personality disorders. Reason being is that in an office-based individual counseling session, and in family therapy, there is one individual, the psychologist, of course, who kind of is running running the discussion, running the counseling session, and those who have conduct disorder or ASPD don't do well with the authority telling them, what they think, and to telling them what, how they should change, and so on. So this actually doesn't work very well at all. And same thing with the family therapy, the child with the disorder would feel targeted and would actually, kind of just go in the other direction. They would not want to be treated. They would not want to be helped, and actually be ineffective in the end. Group treatments can also worsen the problem. So sometimes we talk about group therapy, and group therapy could be a good thing for other psychological disorders, because going into a setting where everyone understands each other, the acceptance is there, the understanding is there, no judgment because everyone in the group setting, perhaps has the same thing, knowing that you're not alone. Those kind of things are really important for a lot of therapies for other disorders. However, group treatments can actually worsen the problem. So, being surrounded by other antisocial or delinquent type of behaviors, peers who do similar things, can actually bring them in deeper and worsen the problem overall. And restrictive approaches, where you keep someone restricted, such as whether it's hospitalization or incarceration, if we're talking about a little bit older, whether it's juvenile detention or actual prison, restrictive approaches also don't work. So by keeping someone, for lack of better words, restricted, there would be no kind of resolution. They wouldn't be able to get better. They wouldn't be rehabilitated, because again, they're very selfish in nature. So for them, punishments, as I mentioned before when I was talking about the behavioral inhibition systems, punishments are not effective because they don't work well. Those with conduct disorders and those with ASPD, they don't feel shame. So if you're incarcerating them or you're restricting them in a hospitalization setting, this is not considered a treatment to them, or it's not considered a punishment, I should say. So it's definitely not effective because they don't have that same inhibition system as a typical individual does. So what can we do? Well, we do have a two-pronged approach, which includes early intervention. As I've mentioned with other disorders, the earlier you treat or the earlier you intervene, the better it can be. And even prevention programs. So before it even starts, educating the parents on what appropriate behavior is, educating parents and children on what proper social skills could be, maybe educating children and parents on how to build empathy, and this is all before conduct disorder even begins. So kind of just overall parent education classes, child socialization classes, all that plus early intervention, if it does occur, is really important. And then if it does occur, conduct disorder or ASPD, having the ongoing interventions throughout. So not all of a sudden putting them in an office or all of a sudden in family therapy or group treatments or any type of restrictive approach, but kind of that education that continues throughout, again, whether it's preschool or elementary school, high school, etc., to hopefully lessen the symptoms so it's not severe, and hopefully that they don't go on a lifetime path where again there's a worse prognosis. So continuously educating children on empathy for others, on proper socialization skills, all these things could be very important for the child. Now there's no cure for psychopathy or being like a psychopath, but you can give therapy to help out. Okay, so again, intervening early, prevention programs. The prevention programs prevents perhaps also escalation of problem behaviors, and then keeping that going. So a little bit more on the early intervention, early intervention or preventative programs. The main assumptions is that, again, you can treat problems easier in younger children compared to older, because again, perhaps this could be due to neuroplasticity, kind of rewiring some of the brain connections that they may have. So the earlier, the better. Again, counteracting risk factors and strengthening protective factors at young age can prevent escalation of problem behaviors. So what this means is that, again, any of the risk factors that might be there, whether it was teratogens in pregnancy or some other genetic factors that can contribute to the likelihood of someone having conduct disorder or ASPD, you can try to counteract that if you kind of intercept it early on. And anything that could be considered a protective factor, like resilience, factors of resilience, you can try to strengthen that when they're young to perhaps prevent the escalation of the problems getting worse. The main assumptions of having early intervention and preventative programs as well is that you can perhaps reduce the cost of criminal justice systems, health systems, mental health, and so on. Because if you give those courses early on empathy and social skills and morals and values and those kind of things, that you won't have to, the government or whoever won't have to pay for mental health and criminal justice as much later on. Now, one example of this type of program is the Incredible Years program. Now, this is a program it's a preschool program that has been offered throughout North America, not just for children with any type of issues, but really for everyone. It's a particular program, almost like saying, someone goes to a Montessori school, someone goes to a YMCA school, someone goes to an Incredible Years program. It's basically a type of program, and it is an intensive, multifaceted early intervention programs for parents and teachers. So within the Incredible Years program, it's not just the children who are attending this preschool program, but parents are also very, very involved in their children's education, and teachers also get involved as well, not just, of course, with teaching the children or the students, but getting involved in the family's life. So the support for effectiveness of early interventions in reducing later conduct problems and maintaining positive outcomes becomes quite evident in the ways that they teach in the Incredible Years program. Now, there's no medication or, as I said, there was no cure for psychopathy, but we can provide therapy. There's also no medication for ASPD or conduct disorders directly. But again, you can recommend medication perhaps for co-occurring conditions like aggression, impulsivity, depression, etc. Okay, so even though we're not treating directly the disorder, anything that kind of comes along with it, we could perhaps reduce the aggression, reduce impulsivity, and mood disorders, and so on. And the last one that we'll look at is ongoing interventions or the parent. So this, again, like I said, early intervention, we had prevention. What can happen throughout with ongoing interventions? We can have parent management training or PMT. So throughout the time that the child is growing up and, developing and perhaps, learning different things from peers, this type of training is more for parents. It teaches them to change the child's behavior in the home and in other settings using contingency management techniques. Contingency management is really the whole idea of reward systems. Okay, remember I mentioned before, they do really, really well with rewards, but you have to be careful, because I did say that those with conduct disorder and ASPD can be very manipulative, and they are very smart and calculated. So they might actually use these rewards, and again, they're very charming. They can say, okay, yes, I will, do the, or I'll stop this certain behavior if I get rewarded for it. So they get the reward and then they just start doing it again. So contingency management is useful because it is reward based, and this does work very well due to their behavioral activation system being kind of it's overgrown if you look at the brain system. But again, you have to be careful with the way that it is managed. The whole focus, besides rewards, is improving parent-child interactions. So this kind of idea of support systems and having at least that relationship and that kind of support within the immediate family is important during this ongoing intervention. It does help promote positive behavior between children and parents, and to decrease some of those antisocial behaviors as well. Although, this seems to be effective, it is pretty demanding on parents because it's something that they need to kind of consider and do throughout basically the whole entire childhood, if it's a childhood onset disorder, or throughout adolescence if it keeps going through there.